60 Minutes with Angela starts right now.
Well, hopefully you won't have any cause to attend the National Orthopaedic Hospital in Igbobi, Lagos State, Nigeria for any reason. But if for any reason you have to, today's program will educate and inform you about the activities of the National Orthopaedic Hospital in Lagos State. In October 2020, Nigeria's House of Representatives Committee on Health rated the National Orthopaedic Hospital's theatre complex as the best among all federal government hospitals in Nigeria. Now, what makes it a place of excellence? And why did the World Health Organization in 1979 decide to collaborate for research and training with this hospital? Well, Dr. Olatunji Idowu joins me on the program today. He's the head of the Orthopedic Special Trauma Unit of the hospital, a fellow of the National Postgraduate Medical College of Nigeria since 2002. He's a former head of the clinical services of the hospital, specialist in adult trauma management, consultant orthopedic and trauma surgeon. Dr. Olatunji Idowu joins me on the program today. Originally, the National Orthopaedic Hospital was a military rehabilitation center.
Exactly.
It was for prisoners of war returning from the Second World War. It was established, I think, in 1945 after recognition by the Colonial Medical Services. It was first called Igbobi Hospital, then Royal Orthopaedic Hospital, before finally arriving at National Orthopaedic Hospital. In between 1945 and 1977, it was administered by the federal government and Lagos State government. But since 1977, it has remained a federal government institution. So what essentially does the National Orthopaedic Hospital do?
The hospital was set up in 1945. Not just for prisoners of war per se, but for those Nigerians that participated in the Second World War.
Right.
And they were injured and had to be rehabilitated. So when they came back to the country, this place was set up as a place where they can be rehabilitated, where they can be treated for their war injuries, and how they can be integrated back into the society.
Right.
So because as at that time, of course, Nigeria was under British colonization, so that was why at the end of the day it became Royal Orthopaedic Hospital when things were made more formal. And of course when we gained our independence from the British,
yes,
then it became National Orthopaedic Hospital.
Yes.
But what we do essentially nowadays
Yes.
is to attend to the modern orthopedic and trauma needs.
I like the way you add modern there.
Yes.
Why did you add modern?
Because now, you know, everything that you do now has to have an international standard applied to it. So what we try to do is to practice orthopedic and trauma according to international standards applied to our society.
Right.
Yeah.
according to international standards. So that means that you obviously offer in-house training as well?
Of course. This center, of course, also is one of the foremost orthopedic training centers in Nigeria and even the West African sub-region. There's virtually no orthopedic surgeon we see in Nigeria that has not at one time passed through Igbobi for one thing or the other. Sometimes people even come after they are already consultants to come and update their training in some other subspecialties.
Yeah.
We offer all that too.
That brings me to my next question. It's not the only orthopedic hospital in Nigeria, is it?
No, it's not. We have sister orthopedic hospitals in Kano,
right,
and also in Enugu.
For now, there's just the three, southeast, in the north, and in the southwest here. In 1979, the hospital became a World Health Organization collaboration center for research and training. Is that still subsisting?
Well, it's not exactly subsisting now. But what happened that time was that when the hospital was established, when it became back under the federal government, it was instantly recognized then as the best and leading, up to now, still the leading orthopedic training center in Nigeria.
Yes.
So, and if you want to get any data then about orthopedic surgery or practice of orthopedic surgery, of course, the best place to collaborate with is Orthopaedic Hospital Igbobi.
Yeah.
That's why WHO came then.
Okay, so it's a wide field with various specialities. For instance, you head the Orthopedic Special Trauma Unit, and your area of specialities, I want you to take us through each one. Pelvic and acetabular fractures, what are those?
In times past, when people have pelvic means the pelvic girdle, and also acetabular means the joint that is formed between the pelvic girdle and the leg.
Right.
When people have fractures in those areas before, people tend not to do anything about it. People just leave them alone, just take care of their general problems, and however they turn out to be, just manage it like that.
What, and how do they turn
But we
out
said
to be?
that's not acceptable.
Can they walk?
They will walk, but they will have some special problems. But we felt that should not be. So we have special training now in trying to actively manage such injuries, such that by the time the person is recovering, he shouldn't have any complication at all. He should be able to walk, just like he or she was walking before that injury occurred.
Yes.
But it's a special, it needed some special skills, some special instrumentations, and some special conditions before you can do that.
And you have all that equipment now?
By the grace of God, we do that routinely in this hospital.
Routinely,
Yes.
I like that. Multiple fractures.
Again, also we have some patients who are severely injured, have 5 fractures. Obviously, it's not every orthopedic surgeon that can just dabble into that. So that's one of the things that we, as a special unit, take care of.
Okay. So
and also, you may see we also do limb deformity corrections.
Yes.
Bow legs, K legs, one leg is shorter or longer than the other, all kinds of deformities. We try and correct them and bring them back to normal.
But I'm sure you heard a lot of people say, if there's not a problem, don't fix it. Do you get that sense from people who are reluctant, for instance, bow legs and K legs to correct?
Yes, well, generally in the practice of medicine, what you need is to provide education to your patients and tell them what you can offer them, what is possible to do.
Yes.
It is what the patient wants that you will eventually do.
Yes.
So if the patient has a deformity and after all kinds of education, the patient still says he wants to be left alone, you respect that wish and leave them alone. But if they want that service, they want the correction, you can jolly well make it possible for them to have it.
All right. Now, complicated fractures that you also specialize in, there are 3 types: non-union, malunion, and bone loss. Take us through the 3. Okay,
just like every other practice of medicine, it's not everything that goes well 100%. Okay, some of our colleagues may have managed the fracture, or some fractures that are managed at lower level hospitals but ended up having problems. They can come to this hospital and we can make things right for them. Like I said, non-union means that a fracture has refused to join together for one reason or the other.
Okay.
So if a fracture has refused to join together and you come to this hospital, we have what we can do to make sure that such fractures eventually unite. And then also, malunion means that the fracture has joined together but in the wrong position or wrong attitude.
Yes.
Either it is shorter, either the limb is shorter, or the limb is mal-rotated, not pointing the right way.
Right direction.
Right direction. Those ones, we also have what we can do. We take down the fractures and then start all over again and reset them.
I like the way you say take down. It means you break and start afresh.
Yeah, well, practically that's what you have to do, but we do it very gently. Put it that way. Then sometimes people have fractures.
Bone loss.
For one reason or the other, a part of the bone is lost.
Well, how can a bone be lost?
Well, sometimes people have very severe injury that the skin is broken,
okay,
and some part of the bone may just fall out. Sometimes the part of that bone may become infected and get eaten up by the infection. So at the end of the day, you still have a place where there's a gap,
yes,
that needed to be filled up.
Yes.
That's also one of our specialties that we.
When you say filled up, with what? Is it like filling a tooth?
No, what I'm trying to say is that we have a way of some things that we can do that will make the bone to regenerate and fill the gap that is existing.
Typically, treatments here are not quick or short term. It's not, for instance, bone loss. It's not something that will be done in like 2 weeks.
No. Yes, things like bone loss, correction of limb inequalities. Most of them are actually gradual processes.
Right.
You may have to do maybe multiple operations, but usually you start with one major operation. And after that, most of the other corrections will be done on outpatient basis.
Right.
I mean, it's not as if we just admit them and keep them on admission throughout.
Yes.
No, we just admit them for a short period of time, do the main necessary operation, and then the patient will be seeing us in the clinic from time to time while all the adjustments are going on.
Yes.
And then if there's any time or there's any need to bring such patient inside to maybe adjust one or two things, we do that. But eventually, at the end of the day, it may take long, 6 months, 1 year, 1.5 years sometimes. The whole condition will come back to normal.
Do people stay the course? I'm thinking 6 months, 9 months. You know, people may start with good intentions,
Yes.
and along the way, they get overwhelmed or get tired of coming to Igbobi every week for 9 months. Is that your experience?
Not exactly. See, when there's a problem, and there's a way to solve that problem, number one of the first things we do, you don't just jump and start doing operation right from the one. We sit down with our patients, we educate them, we let them know what it takes to get to the end of the road, of the journey, yes. And then we kind of motivate them. And also, there's something we call, patient selection. You need to also select your patients. You need to know those who can go the whole hog, And it's not even in terms of just coming to the hospital.
Yes.
And of course, it's not every week that we see them, actually. That would be too frequent. Sometimes maybe every month, once in 2 months. Something like that. And then also, it's also financially demanding.
Yes.
So even from day one, you need to be able to know those that will be able to complete your treatment. It's not that you go halfway, then you stop.
Yes.
But having said that, we do encounter such problems. Along the way, the patient gets discouraged.
Yes.
But we get the support services of many other professionals. We have psychotherapists, we have psychiatrists,
Yes.
we have physicians that will also help us
all in-house.
Yes, that help us to, pep out all these patients, and then at the end of the day, so that we can get the desired endpoint.
Get the results.
Yes.
Do people make a complete recovery?
Sure, a lot of people do. That's the whole essence.
Because the oldest myth I've heard about Igbobi, when anything happens and you tell people go to Igbobi and say, they will cut your leg. It's like that's what people think you do here.
Yes, you can see I'm smiling. I knew that question is going to come up on top of the other. Yeah, well, in the olden days,
yes,
you see, even as at that time, it's also as if we were cutting limbs of people. No doubt about it. I think where the confusion actually starts from is the issue of doing an operation to solve a fracture.
Yes.
People just think that once you say you're going to do an operation, that what you're actually going to do is to cut a limb.
Yes.
Because you may open up a limb to do some operations there, but it doesn't mean that you're going to cut off the limb.
Right.
Are you getting my
Yes.
Yes. So people just tend to get that wrong in the beginning. But sometimes common sense, when you apply common sense, of course some people say common sense is not so common.
Yes.
Is that why will anybody just see a limb that is good and you come to hospital seeking for help
And they cut it.
and all they can do is to cut off the limb? I mean, it doesn't make sense. You get what I'm saying?
Yes.
Then secondly, before any operation is done, you need to get the consent of the patient. That this patient has to get a thorough explanation, an informed explanation. The patient has to make up his or her mind about the operation and have to say, okay, I have been explained to, I understand this operation, and I'm signing up for it. So you can't just come and somebody just grab your leg and cut it off.
Yes.
Then for those who are, I will use the word unfortunate, to actually end up with an amputation, because an amputation is also correct treatment for a lot of conditions. If somebody, for instance, has a cancer of bone, for instance, now,
Yes.
we all know that for cancer, most of the time you need to remove that part.
Yes.
So if you have a bone cancer in the leg, of course the leg has to go.
Otherwise, the cancer will spread.
Exactly. So such patient may need an amputation. But even for such patient that needed an amputation, they needed to consent to it. And a lot of the time, they actually even need to pay
For it.
They don't dash people operation. They don't dash people amputation.
So
So there's no way anybody
even
will
if
just
they're
come.
going to amputate me, I'm going to
Even
pay
if they're
for
going to
it.
market, you still have to consent to it. You still have to pay for it. So nobody you can just grab you and just do an amputation for you. People should just disabuse their mind over this. There's no iota of truth in it.
Yes.
That they just come and they just amputate your leg. Furthermore, I will also shock you to produce an orthopedic surgeon.
Yes.
Of course, you all know you have to have primary school education, secondary education, have to graduate as a doctor.
Your MBBS. That takes
Then you need to
7
come
years.
back and specialize in orthopedic surgery, spending another sometimes 8 to 10 years before you become an orthopedic surgeon, all to cut leg. I mean,
It doesn't make any
it doesn't
sense.
make any sense at all.
Yeah.
So please, there's nothing like that. We don't just cut leg at Igbobi. We operate people. We operate fractures. Sometimes some fractures cannot be brought back to normal unless you open it up and you set it from inside. That is what we do.
Talking about opening it up, I think from researching this in this interview, a lot of people tend to think that when they're coming to Igbobi, they're just going to come and do POP. I don't know if you get that sense from them. So when you talk about going in and opening up the leg, that's not what they bargained for. They thought they would just come and you just wrap the leg or the hand in POP and that's it.
Yes, there are many ways you can manage a fracture, depending on the personality of the fracture.
Yes.
Okay, no two fractures are the same, like we orthopedic surgeons like to say. Now there are some instances where you can get away with just wrapping a POP around the fracture, the POP or the modern one that we use now called Scotch cast.
Yes.
And that can lead to healing in the proper position. But sometimes a bone is broken and the two ends are scattered, they are far away from each other. Sometimes we can still be able to bring those ends together reasonably well.
Yes.
And still put POP. But in a lot of time, you cannot do that. No matter what you do, those bone ends just will not come back together. That can be for a number of reasons which we cannot go into now.
Yes.
But when you see that kind of circumstances, you know that you needed to open this fracture to make the ends physically meet. And then while you are there, you also need to hold it with something. To know that when you close it back and you turn your back, it won't scatter all over again. That's what brought about the essence of operating a fracture. So what we're just doing, just to make sure that the bone is well arranged, so that when eventually it heals, it will just be like nothing happened there. So then, because of the practice, that people have been practicing, have a lot of experience. There's some fractures that you know from the word go that they're never going to do well unless you operate them. For instance, most people that have a fracture of the thigh bone called the femur, the amount of flesh around that bone is so much that you cannot set it from outside.
You must go in.
Just go inside. And also, nowadays, we also believe that you cannot, because you have a fracture, now go and stay in bed for 3 to 4 months. That sometimes it takes for that fracture to heal.
Yes.
So it is advantageous to fix that fracture inside and be free outside to be able to still carry out some of the activities that you are used to doing while the fracture is healing. So to operate a fracture has many advantages.
Yes.
And it's also in tune with normal practice of medicine now. And that's what we offer our patients.
Join us again after the break. It would seem that this hospital is so highly rated that people are referred to you from other hospitals. Why would somebody be referred to Igbobi, for instance, from the Orthopaedic Hospital in Enugu? And does Igbobi reciprocate that? Do you refer people to other hospitals, or is only you that people are referred to?
Okay. There's a general cooperation among all hospitals. A referral can be from a peripheral hospital to a specialist center, and sometimes it can be the other way around. Right. Now, our colleagues that works in Orthopaedic Hospital Kano and Enugu, for instance, we all have basically the same training, the same, we attend the same colleges, we have basically the same qualification. But when it comes to sub-specialty, we are kind of different.
Right.
Sometimes you find somebody who is very good at a particular procedure, and you can say, oh, my colleague also has a good peculiar solution to this problem. You can go see him. Then another thing is that sometimes you may find somebody that lives in Lagos and went to do something in the east and met with an accident there.
Yes.
You may go to
Enugu,
had a basic procedure or what we call resuscitation, and then you can say, okay, now since you stay in Lagos, why don't we just refer you to Orthopaedic Hospital in Lagos so that you can have your treatment at a place that is near you.
Yes.
And then, so vice versa, everything happens like that. Anybody can get referred anywhere.
Why should anyone choose to come here as a patient?
Well, at Orthopaedic Hospital Igbobi here, we offer, like I said, specialty, sub-specialty facility for a lot of our patients. I will just name them.
Yes.
Apart from our own unit, which is Orthopaedic Trauma or Special Trauma Unit, we have what we call the arthroplasty unit.
What do they do there?
Arthroplasty is the procedure where you change or you resurface joints. We know the problem of arthritis.
Yes.
Is very common. A lot of people have bad knees, bad hips. Now, we have taken our own practice to such a level that we routinely do all these operations. So we have such subspecialty here. But we have 2 units that all the doctors are doing there. They are dedicated to joint replacement. So that's one. Then we have spine surgery unit. Anything that has to do with the spine,
yes,
the vertebra, right from the base of the neck down to your butt where you sit down. Anything that is wrong with the spine, with it here, whether it be injuries, deformities,
yes,
and also, well, arthritis of the back, which we call spondylosis.
Yes.
All those things that you must have heard about radiculopathy and all those things that are common in those. Yes, we attend to all those problems here. Okay. And we're very good at doing it. Okay, so let's move to another one. Pediatric orthopedics. That is orthopedics for children.
Right.
All children's peculiar problems. We also have units that deal with that. Then we also have arthroscopy and sports medicine. We have doctors also that are specialists in that. They usually do a lot of procedure using the principle of keyhole surgery.
Right.
And they put a tiny telescope in the joints, and through that they should be able to view the joints and find out what is wrong, and sometimes do necessary operations to correct it.
Is that because you need the sportsmen to be able to go back to their...
Exactly. A lot of our sportsmen actually are coming to this hospital now. And we, for those who are familiar with soccer, you heard that one player has had anterior cruciate injury and all that. Yeah, we do them here routinely through keyhole surgery.
And they can play again after cruciate?
After due rehabilitation, they can still go back and play their football. We also have the orthopedic oncology unit.
That's cancer.
That's cancer. Any cancer that has to do with bone, they are specialists in also doing that.
Yes.
Then we should also must not forget that this hospital is also have a very strong unit in bones, plastic and reconstructive surgery. Yes.
Now, you want to differentiate that from cosmetic surgery. It's not the same.
No, cosmetic surgery is part of bones, plastic and reconstructive surgery.
Right.
And we actually do some of the cosmetic surgeries too here.
Yes.
Yeah, we do. And also now we also do what we call limb reimplantation. I mean, if somebody's finger is cut off or a limb is cut off, you can reattach it.
If they find it.
Yeah, if you bring it, and in good time too, you can reattach it.
Okay, so just to educate the viewer, if a limb is excised,
and
what do you do immediately? Look for ice?
Yes, just wrap the excised part in ice and come to the hospital immediately. Well, it's not in every case that this can be done.
Yes.
But if the conditions are right, if all the criteria are met,
yes,
you can reattach it back.
And it will still work?
Yeah, it will still work. And indeed, we have reattached fingers and toes. Also, we also have a special burns unit. We specialize in treatment of burns.
Why do you need burns unit in an orthopedic hospital? I thought it's just
an orthopedic and trauma hospital.
Right.
Burn is a trauma condition, and in fact one of the very severe trauma conditions. Apart from even that, even in the orthopedic conditions that you mentioned, see, the bones are covered with flesh. Okay, and a lot of time when the bone is injured, the flesh also gets injured.
Right.
And for you to restore back the bone, sometimes you need to first restore the flesh.
Yes.
And we know that our burns, plastic and reconstructive units, that's their specialty.
Yes.
So we all work hand in hand. Sometimes when the patient, let's say somebody had a motorcycle accident with a very deep gash on the leg and the bone is broken, right from day one, both the orthopedic surgeons and the bones and plastic people meet together
to chart
a way forward for such patients, so that at the end of the day, both the flesh and the bone are restored back to normal as much as possible.
I can't imagine the things you have seen in this hospital. All right, so now there was a time that the hospital premises was littered with victims. I remember especially of victims of motorcycle accidents, which we call Okada here, and others. And you had many incidents of patients also abandoned by family and friends. How did the hospital move away from that place to where you are now, currently?
Okay, the issue of abandonment of patients has always been with us, and even though it has reduced to a large extent now, but the fact is that we still have them occurring like that occasionally. I think the basic problem is that it's that of lack of funds to take care of the patients. You know, a lot of patients come to the hospital and they just don't have the money. And unfortunately, the government does not have a basic, or should I say, program for taking care of such patients.
Yes.
So a lot of people get abandoned in the hospital sometimes. But the hospital itself has taken it upon ourselves to sometimes try and raise money for our patients. We have a very good medical social unit that sometimes go out of their way to source funds to treat some of our patients. And then maybe I should just use this opportunity to thank a lot of our donors that have partnered with us. We get a lot of people who just come to, some people just walk into the hospital and say, okay, do you have anybody that is owing money? We Nigerians, we actually still very, very good people.
Really?
Yeah, some people just walk into
So people watching us now who
Yes.
would like to donate to the hospital.
They can do that, they can get in touch with us. Some people just come and say, okay, do you have anybody that's owing money or that doesn't have money for treatment?
Yes.
And then you have like maybe, as at that time, you have like 6, 8, 10 people. Somebody will just pay for 4 of them and walk away. And then of course those 4 people will be promptly treated. So with that and some other corporate sponsors,
yes,
we've been able to reduce the incidence of people being abandoned in hospital and all that.
Yes.
But having said that, I will also say that a lot of the things that we are doing are still highly subsidized.
Yes.
So when you compare the charges in this hospital with that of private hospital, you see that it's much less.
Yes.
Because it's not everything really that is being charged for.
For quicker services to avoid delays, of course, delays are typical of government hospitals. You also have a public-private partnership in operation here, because now we're able to do x-rays and some diagnostics on site, as opposed to years ago when they would send you to different laboratories. How did you evolve that?
Okay, well, sometimes it's part of government policy actually that where some services are not being provided by government themselves, that we can do some public PPI, they call it that time, public-private initiative.
Yes.
And then it was one of such things that got us some services that we use it. Like now, you can see that we have an MRI and CT center.
Yes.
Now, like you mentioned before, sometimes we needed, these investigations are very crucial for some treatments. But in the past, then we have to start carrying people with ambulance and then to go to various centers in town.
Yes.
We are sometimes exposing the patient to further harm.
Yes.
But now we've been able to partner with some people who brought the machine to our compound there. So that all you just need to do is just wheel the patient from the emergency or from the ward to the facility, have your investigations done, and then back.
And
so
makes
it's a
everything
good,
faster.
Yes, it makes things faster.
Once the results are out, the doctor knows how to move.
Exactly. So in that wise too, we also, even the hospital itself, in order to reduce medical tourism and also to cater for what I call the upper echelon of the society, people who will normally probably just go abroad for their treatment. The hospital also established what we call an amenity center. It's a kind of fast-track private hospital-like facility within this same hospital, where people can come and get services that are comparable to what you get in any standard hospital in UK or the US.
Yes.
And then
with
also get your privacy.
Yes,
everything. Also get your privacy. So, and then I think with that too, we could a little bit say that we can cater for any strata of the society.
There's also a 2-tier practice system in place, which you just talked about, tackling the need to travel out for critical orthopedic surgery. So take us through what happens. If a patient comes in now with injuries, how do you decide, how does the patient know which one he will do? Is he going to go for this, one targeted for the high net worth individual, or
Okay, you need to be very careful.
Yes.
Normally when the patient comes to the hospital, they just go straight to emergency.
Right.
Yeah. At the emergency, there is 24-hour service. Doctors are always there. Any time of the night. There are always medical officers on duty to attend to any patient. And there's always what we call a team on call that is ready to review any patient that comes at any hour of the day. Okay. Now, most of the patients that comes to the amenity center are usually by referral or by appointment. I get me.
Yes.
But most of the time, and they're not the people that actually come to our emergency, but people who have had the place is it's almost like how do I put it now? By networking here, let's put it that. You know, sometimes to some of our patients that come to emergency here after their resuscitation, after they have been attended to, and all emergent conditions remedied,
Yes.
and they are now kind of stable.
Yes.
That's why such people be not answered. You see, you know, we human beings, you know, from the way we are. When you are in an acute situation, you don't remember your privacy, your convenience at that time.
Yes.
But when people are now okay, and I told them that okay, you needed an operation for this, you know, when they ask, somebody may ask and say, is there no other way that we can do this thing? You know, such patient might not end up in the amenity center. But most of the patients still goes to our normal emergency.
Yes.
And then there are some people who, because they've heard about the services before, they will phone in to say, okay, I have this condition, I learned that you people are doing this, can I come?
Yes.
And you say, you come.
Right. Okay, so, all right, join us again after the break. Welcome back. Now, certain orthopedic injuries are common to certain age groups and gender. So I wanted us to talk through the different age groups. We start with age 0 to 5 years old.
Okay, yeah, they talk about what we call the pediatric orthopedic age group. I think probably the most popular among them will be what we call clubfoot. I don't know whether you know, whether you know that.
What causes that? They're born with it?
They're born with it. This hospital actually has a dedicated clinic for the correction of such deformities. We've been doing it for years.
Clubfoot and cleft?
Clubfoot, for cleft,
Yes.
cleft lip and palate.
Yes.
Our colleagues in the bones, plastic and reconstruction surgery unit,
Yes.
they also do that too. Things like multiple digits,
More than 6.
absent digits, stock digits, when two of them are stuck together, or web digits.
All the 4 stuck together.
So those things are very common.
With children.
And also deformities of the limbs that are the rickets,
Yes.
bow legs, K legs, all of them. That's when you see all those kind of
Do you battle this idea that some of these things may be spiritual with people who bring children, or is it, you know, up to age 5?
We are scientific, and we know that such things are not really true. But I won't say that as a human being, you know, to say that things are not spiritual is to probably to be fooling yourself.
Yes.
But the problem is that people tend to, what can be corrected physically,
Yes.
people will try to find spiritual solution to it. And that's where people get things wrong.
All right. So age 5 to 16.
So sometimes some of the childhood problems will still persist to that age. You know, like now for one of the causes of bow legs, for instance, it's called Blount's disease. Even at that, even if you correct them, sometimes when they're babies, sometimes still recur, still go into the other age group.
What's Blount's disease?
It's a kind of bow leg that is due to problems in the growth of the bones of the leg.
Right.
Such that as the bone is growing, it will always curve and make a bow. And until such a child reaches maturity, as long as that child is growing, the leg will continue. The bones will continue to bow. But we also still advise our patient to get a correction. We know that correction will still recur. But if you leave it until adulthood, it will have gone so bad that it will be difficult to correct.
Correct.
Then as the child goes to higher school and all that, of course, more activity, more fractures. And then there's also some other peculiar conditions of the hip that we call the slipped capital femoral process, which there is a separation of the growth plate of the hip.
Yes.
That also occurs in that age group too.
Why does it occur in the age group? I mean, what predisposes them to it?
Yes, sometimes it's some of the hormonal changes that are occurring during that period of rapid growth. Yes, specifically weakens that place such that it just sometimes with minimal force, it just behaves like a fracture and breaks. So, but it's not in every baby, every child that will occur. It has some peculiar children that will occur in like that. And then, so when they have pain in the hip, we should suspect that something like that may. Again, in this age group, some growth abnormalities may also occur. You may find one limb or the other getting longer or shorter, depending on what happens to the bone.
Yes.
Bone infections are also common in that age group too. Chronic osteomyelitis, we call it.
How would you get a bone infection? I mean, there's flesh covering the bone. How did the infection leave the flesh and go into the bone?
Yes, most bone infection actually from through the blood.
Right.
That somebody has a boil somewhere, that boil has a lot of germs inside it. Sometimes the germs invade the blood and then travels to the bone. Well, because of the peculiar way the circulation in bone is designed, sometimes the germs get sequestered in an area of the bone and establish a new infection that now persists inside the bone. So simple things like sometimes even tooth extraction.
Yes.
Some germs may enter to that place and end up setting an infection inside the bone.
This is why they say self-medication, one should really avoid it.
So, but usually when you have such things, the best thing is go to the hospital. And if you go to the general hospital and the doctor there thinks that this is an orthopedic issue, can send you to see the orthopedic surgeon. Such things, of course, are best managed when they are very acute, so that they don't become persistent and become chronic.
All right. Okay, so age 18 to 40. I don't know if that's too wide, but
it's not really too wide, but that's adulthood, really. In this age group, what is more common is injuries, fractures, and all kinds and patterns of fractures.
Are any of these injuries exacerbated by lifestyle? For instance, if a person is 32, 35, drinks heavily, smokes heavily, or is diabetic?
Yes, of course. Such things will always modify what will normally occur in other people. Of course, the person drinks a lot and get drunk. I mean, you can be highly predisposed to having accidents on the way.
Yes.
Endocrine diseases like diabetes mellitus also may affect the outcome of the treatment that you give to people. So there's no way your lifestyle will not affect your predisposition to and also the outcome of treatment of these orthopedic conditions.
I understand that one of the major challenges for orthopedic surgery is diabetes. It doesn't allow full healing if it's not corrected or controlled is the word.
Exactly.
If it's not controlled and the orthopedic surgery or treatment is undergone, it may ultimately lead to amputation. Is that true?
Yes, in some ways. Actually, diabetes mellitus is a multi-organ disease.
Yes.
Even though it starts as an abnormality in the metabolism of sugar in the body. But it in itself causes some orthopedic conditions. The classical of which is what we call the diabetic foot. Diabetic foot syndrome.
That's when you have a wound on your foot and it will never heal.
Exactly. And if you don't manage that quickly, it may actually lead to gangrene, of which amputation will be the only solution.
Yes.
Now, apart from that, for the normal orthopedic conditions that people have, diabetes can also complicate them and sometimes making them more difficult to manage. For instance, now if somebody has just a routine fracture that needed an operation, and the person is diabetic and his control is out of control, no surgeon is going to operate such person until you are able to control the diabetes. And also, the morbidity, that what we call the overall effect of that condition on the body is worsened by diabetes. So diabetes mellitus is a very, very important thing that one needs to be aware of, especially with orthopedic conditions. And the same thing with high blood pressure, hypertension. It is such a situation that led to this hospital even employing physicians. We have an endocrinologist, we have a cardiovascular physician that help us to manage all these people pari passu as we are going on with the orthopedic problem.
So when they come in with orthopedic problem, all these factors matter.
They matter. And when we see them as surgeons, we call in our physicians to help us ameliorate some of these issues.
Yeah. So let's go to age 40 to 55.
Okay, 40, we ended at 45.
Yeah.
For the 45 onward, I think what you see more are the degenerative diseases. The body is getting old, joints are getting arthritic, the back is getting worn out. And so people tend to come more now with problems of the back, radiculopathies and all that. They tend to have more problems of the joints, arthritis and so on. And also what we can do to ameliorate some of these problems. Then a little bit later, because of osteoporosis, that is weakening of bones, we tend to have some peculiar fractures that occur.
And this for women from which age? 55?
55 upward, yes.
So that's not a good time for a woman to fall
Exactly.
and break the thigh bone.
It's not.
With arthritis, is there any time that invasive surgery may be needed?
Yes, that's what I mentioned in the beginning. When a joint has arthritis and the surfaces are damaged,
yes,
the cure that you can give is to replace the joint.
But is that successful all the time?
Well, as you can say, but it's an invasive procedure, just to use your term.
Yes.
Yes, it is successful all the time. Within acceptable limits.
Right.
See, the aim, or what we do in joint replacement is really very simple.
Okay.
See, if you look at a normal joint,
Yes.
a normal joint is covered by cartilage. Excuse me. Now, cartilage, the way God made cartilage, God did not put the sense of pain inside cartilage. So that covering, that whitish thing does not feel pain.
Right.
But as you are using it, it's wearing out. It is when the bone that is underneath starts showing, that's when people start having pain in their joints. Because bone has a very acute sense of pain.
Yes.
Okay. And then the wearing continues, the pain continues until such a time that when the pain becomes constant and life is miserable.
Yes.
So when you say you want to do a joint replacement, what you actually do is just open up the joints, scrape off the remaining cartilage, and then replace that cartilage, and you stick something on that is made of artificial material. Are you getting me?
Yes.
Which, of course, will not feel pain. Are you getting me?
Yes.
At that time that you are doing it, if it is for the knee, for instance, now you can also use that opportunity to correct whatever deformity may have been at the knee, whether it's a bow leg or K leg or whatever it is. And then you now put that inert material on you stick it on the surface.
As if it were cartilage.
As if it were cartilage. And then you now couple the joint back. So again, now you have created a situation in which you have an inert material that does not feel pain. Are you getting me?
Yes.
Also, on top of that, is also another thing that does not feel pain. So the patient does not feel pain anymore. And so you can regard that as a cure.
Yes, a success.
Because for many years to come,
you won't feel pain again.
Exactly.
We'll have the same function, the
That's
limb.
why the only thing that those things that you put on top has been so designed as to look exactly and function exactly like the cartilage that was removed. So it is this time around. It's not management; it's a cure. Are you getting me?
Yes.
Because from that time onward, the person should be able to walk much better than he or she was walking before, and also function normally.
How long will a surgery like that take? How many hours? And I'm sure it won't be cheap.
Well, it may not be cheap in the sense that the prosthesis, those material that you put on them, none of them is
custom made.
Yeah, apart from that, they are not made in Nigeria. They are imported material, so their prices obey the law of dollar.
Dollar, yes.
Exactly.
I had a client once, a woman who had this ball joint, this ball that goes in, I think the hip one, yes. Yeah. And they had cause to go in a second time. She did the first one somewhere. And I told her about Igbobi. She came here and they did it a second time. She kept having pain. The pain never stopped. And she was told, oh, it was an infection. The thing was already infected when they put in the ball. So, you know, are these normal risks associated with this kind of surgery?
Yeah, for any surgery, actually, for any surgery, whether it's orthopedic or even non-orthopedic, there's always a risk of infection. And that's why operations are done in a special place called theater, with some special materials that the surgeons dress in a special way.
In a sterile
environment.
Yes.
It's all an attempt to reduce the incidence of infection to the barest minimum. Now, we also recognize the fact that in orthopedic operations, usually the orthopedic surgeon would leave something behind. Like you said, the ball joint, metals. That also comes with an increased risk of infection. But the process leading the operation to the operation itself is such that these things have been taken into consideration. And every attempt is being made to make sure that that infection does not occur. But like I said, there's nothing in life that is 100%.
Yes.
But sometimes when you do operations at lesser hospitals, sometimes they may not have been as careful. And they may have been, like you said, that patient already has some infection when coming.
Yes.
So such things makes what you do has a lot of impact in what you do later. But usually, that risk is very minimal. And it's, of course, one of the things that we explain to our patients. Because sometimes we need to get their own cooperation to make sure that such things do not occur.
Yes.
Like that, before they come to us, we would like to know, do they have any pre-existing condition? Do they have cold? Do they have UTI? Have they just extracted the tooth when you expect that there will be a lot of germs in the body and all that? So, but by far and large, the risk of infection is very, very minimal.
Well, on a final note now, Igbobi Hospital has a bone bank. They say it's bones generated from arthroplasty patients. Okay. What is a bone bank?
You really read a lot about our hospital, I must say. Now, what happens there is that when we were talking at the beginning, I told you that we manage bone loss or bone gaps. A lot of conditions are that we need what we call a bone graft.
Yes.
That is, you need to put some bone somewhere where there's a deficit. Or sometimes you need to put some bones when you want to stimulate the body to grow its own bone.
Yes.
Now, we used to take this bone, sometimes we used to borrow it from the patient's body, from another part of the body.
That's when you go in and take from the
For instance, if somebody has what I call a non-union of bone, and you've tried to go and put the bone back together, you need to put some fresh bone there to restart the process of healing. And so you can get such bone from the patient's body.
Yes.
You can go to the hip, or sometimes to just below the knee, to get such biscuit bone and add it. But if you picture a situation in which you need a large amount of that graft, and you know that taking it from that person's body is going to now create harm in the patient's body.
Yes.
So you need to get the bone from somewhere else. Now, sometimes you can get artificial bone or synthetic bone. Number one, they are very, very expensive, and they are not quite as effective as
the
patient's or a human bone. We as orthopedic surgeons, we generate bone every day. Like if somebody calls for arthroplasty that we just said now, and you're going to remove somebody's hip bone, that is bad.
Yes.
And you're going to throw it away and replace it. So we ask ourselves, why do you throw it away?
There's still some parts of it
Why
that
don't
can be
you
used.
process it in such a way that it can be useful to another person? So that's how the idea of a bone bank occurs.
How do you keep a bone alive?
That's what, I'm going to come to that. We don't actually need it to be alive. What we need it to be is to be free of infection.
Right.
Are you getting me? And also not to contain any transmittable disease. So the process starts from, if you want to do, let's say, an arthroplasty for a patient, for instance,
Yes.
you need to know that such a person does not have any infection. You need to get the consent of the person that, okay, this is your bone that we are going to remove. Can you give us permission to keep it? If the person gives the permission, then go ahead. So after it is removed, it goes through a process of sterilization, free of disease, and that has to be kept at a very cold temperature.
Which means no electricity failure.
Yeah. And so there's a special refrigerator for it, and you put it inside. But before that, we'll have taken it for irradiation, a lot of process actually. But the fact is that because that bone bank exists now, there are actually some procedures that we were not able to do before. Because we need large amount of bone that we can now do. Now, also in the beginning of this talk, I said that when somebody has a cancer of the leg, for instance, that the person needs to have amputation.
Yes.
Now, it's not possible for people to have cancer of the leg and you don't amputate them.
Because you have
Yes, you can. If you get them early, you can go there and cut all the bone that it has the cancer off, leaving a huge gap. And with all this bone bank and scona, we can now fill that gap with new bone and say conserve the limb. So that's why you have that bone bank. That bone bank is so useful that almost all the hospitals in the southwest come there to get
bones now.
Exactly. So it's a good development for our environment.
Thank you very much, Dr. Idowu, for having me in your office today and educating me on everything orthopedic. It's been an interesting conversation.
You're welcome.
And thank you for watching. I'm Angela Ajetunmobi.